Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jen Stallings.
Today we're going to be talking about breast augmentation with Dr. Tom McClellan, and he's with Morgantown Plastic Surgery, affiliated with Mon General Hospital. Mon General Hospital brings you Health Talk every Thursday morning at 8:35 here on WAJR. And my co-host, of course, is Kay Murray. Good morning, Kay.
Yeah, and we're going to focus really on breast reconstruction this morning.
Okay, so why do women get breast reconstruction, Dr. McClellan?
That's a great question, Jim, and thanks for having me back. I feel like I should
Welcome
be on top of
back.
the town. I'm here all the time.
Welcome anytime.
Very comfortable. Breast reconstruction, basically we perform after a woman either has a lumpectomy and has a malformed breast, or a mastectomy for breast reconstruction, which is done by the general surgeon. And basically we restore form, symmetry, and shape of the breast for the woman to kind of get her past the act of going through breast cancer. And it's really the last phase of that. And we work really closely with the general surgeons and at Mon General. That's High School King Burns Tallman and Mark Johnson and Jerome Johnson over at Mountain State Surgical. And we really work closely as a team to help the woman when she comes in and she's diagnosed to formulate a plan, get her through the system very quickly, and get her back whole again.
And so it's not a very long process?
It can be a long process. It depends upon the pathology, it depends upon the woman, what her health history is. Every patient is different, and that's why you have to have a kind of a nimble team that works closely together. I think that's why I hate to toot Mon General's horn. Mon General is a really excellent hospital. I trained in Boston. I did fellowships in North Carolina and at Emory and Duke. I really feel Mon General is one of the best hospitals I've ever been at, specifically because of the care. The close doctor care.
Let's go back to the mastectomy. And can you do this reconstruction immediately after, or would there be a waiting period?
That's a great question. My personal preference is to do immediate reconstruction, meaning that when the woman goes to sleep to have her mastectomy, that I can come in while she's still asleep, perform a breast reconstruction, at least the first stage of it, by placing a tissue expander behind the pectoralis muscle and a little sling, which is made out of cadaveric dermis, that holds the tissue expander under her pectoralis muscle. I'm not able to fully expand it, but I can get a jump on the reconstruction by putting in saline immediately in the tissue expander at the time of
So there would
surgery.
have to be another surgery following that?
There's a second stage that occurs usually about 3 months later if everything goes well. And generally in between there, the nice thing about breast reconstruction is in the last probably 6 or 7 years, we have come so far in improving breast reconstruction, how we do it, how fast we do it, and what the results look like afterward. And that's really key, because a lot of women have a view of breast reconstruction from the 80s and 90s, which we were not good at.
Right.
It was much more deforming and much more difficult. So generally when women have the mastectomy, I come in, I put the tissue expander in, so that when they wake up, they have some form to their chest. And it really helps them kind of assimilate what's happened, and they feel immediately better about themselves. With the new techniques, I'm able to really insufflate maybe 1 or 2 times, putting saline in the tissue expander just in the office, versus 8 or 9 years ago, it may take in 15 to 19 insufflations. So we've really decreased the amount of time that it takes to get fully insufflated before you're ready to go.
Let's talk about the type that we're talking about, the reconstruction. There used to be, there's silicone or saline, is that it?
Sure, saline.
Saline. And wasn't there some controversy over one of those in the past?
There is. So as far as breast reconstruction goes, there's actually quite a number of different techniques, okay? One we'll talk about today is tissue expander. It's really what most women want, because it gets you back to your life the fastest, typically. There are muscle flaps. There are very difficult muscle flaps like free trams, which is taking tissue free from the body and putting it on the chest. There are pedicle flaps where you move them around but keep them connected to the body. And then there are implant reconstructions. And basically there are 2 types of implants. Saline, which is just a fluid that normally occurs in your body.
And that's what you've brought today?
That's what I brought today. And this is a tissue expander, which is the first stage. And then there's the silicone implant, which is the final implant that's placed in. Back in the 90s, they were very thin-shelled, and they were actually liquid silicone. And what they found is that when it's squeezed on the implant, it could fracture, and then you'd have liquid silicone in the body.
You have a leak, which
That's correct. And you could get silicone in the lymph nodes, et cetera. And there was some thoughts that it could cause some immunological illnesses. And so far, that's been disproven with multiple studies. It's the most studied medical device of all time. But what it did lead to is the next generation of silicone implants, which are much thicker shelled and actually now are a cohesive gel, like a gummy bear, so that if they fracture, they stay together.
And what's the aftermath of all this? And after you have the follow-up surgery, then what? Do we still have to continue to come back, or do we heal? And
Sure. So really, it's a 4-stage procedure with a decreasing operative commitment, so to speak, at each stage. So the first stage is the largest because you're going to have your mastectomy, the tissue expander replacement. You generally are in the hospital about 2 or 3 days. I generally use 2 drains on each side, and we'll talk a little bit about why that's good and bad. And then you come back once you recover. You have some insufflations of the tissue expander in the office, generally 2 or 3. I let everything stabilize for 3 months. Then you come back for your second stage. At that stage, we take out the tissue expander and we place a soft implant, and we make any changes that we want to make.
And recovery from that would be?
Day surgery, you go home right after, very short recovery. Generally, about a month after that, I make a nipple in the office under local, and then the final stage is just a tattooing of an areola, which is, obviously just our procedure.
So this, what you brought in, is a tissue expander.
Yes. So basically, every surgery has.
Hold that up for the camera, though, too. Yeah, so.
Every surgery has its problems, and one thing about allograft tissue reconstruction. So previously, maybe more than 10 years ago, they had the mastectomy that took the skin. And what happened is when you take the skin, it's very tight, and you have to put the tissue expander in flat and then slowly expand it over time. You had to come back to the office 19, 20 times. It was painful, and the results were not that great. With the advent of the skin-sparing mastectomy, what we're able to do, and people on your camera can see it, if I have the breast and then I remove the breast tissue but leave the skin behind, I'm able to use that soft, supple skin that we just can't grow or create with the tissue expander. So what we do is when we lift up the pectoralis muscle, we place a small sheet of allograft material, which is a treated dermis, as a hammock to hold it into place.
So you go under the breast.
Go under
the skin.
the
Under the
muscle
skin.
and under the skin. And let me show the camera. I brought a
That's one good thing about being on camera
little
today.
cartoon, and you can see this little sling right here.
Yeah.
And what we're able to do is when we place it behind the muscle, now we're able to hold a fully expanded or near fully expanded tissue expander in place.
It's already inflated?
That's correct. So we've got a huge jump on the breast reconstruction itself. So the woman's time of being non-whole or without a breast is much shortened, and actually their outcome is much improved.
What's in there? It looks like orange Jell-O. Is that
What I
saline, or
did,
is that...
so one of the problems with allograft reconstruction are 2 things, and there are multiple studies. I had learned it from the guy that invented it at Brigham and Women's in Boston. He basically, you can get a seroma, which is a collection of fluid that would have to be drained, or you can get an infection. And seroma infection rate's about 10 to 15%. The problem is if you get an infection, you have a very limited treatment option, or a seroma. If you have a seroma, let's say you get fluid on your knee, and you go see the orthopedic doctor, they just stick a needle into it and draw off the fluid. Well, if you get a seroma around this tissue expander, and you have a needle, obviously you can't stick a needle in it and drain off the fluid, or you would puncture the tissue expander, and the woman would have to go back to surgery. So that's one problem. Second problem is, what if you get an infection around the tissue expander? Okay, so this is covered in a pocket of skin. Okay, if there's fluid around here, there's no way to draw off the infection. You can't sample the material to send it to microbiology and find out what bacteria it is. And more importantly, you can't treat it because there are no blood vessels here. You can't deliver antibiotics to it. Okay,
Right.
So the only option is I put them in the hospital. You put them on IV antibiotics for 24 hours. If it's not any better, you take it out. So that's another surgery for the woman, number one. Number two, you can't put anything back in. So they have to go flat, and that's really difficult for the woman to go through.
Yes, it is.
So when I was a fellow, we had problems with these. So I started to think about it. I'm a tinkerer, as probably many people know. But so what I did here is this is a kind of a sample of what I'm talking about. So I put yellow food coloring in the tissue expander. This is just water to show if this is inside your body. And I'm putting it in a Ziploc bag. And inside the Ziploc bag, I have red food coloring, okay?
That's to signify blood or bodily fluid.
Yeah, or seroma or infection or something like that. So let's say that this is inside your body.
I feel like Jim's doing a play-by-play here.
He is. Where's Caridi when you
Yeah,
need her?
well, I know, yeah.
So now imagine you can't see through this, okay? But you have this fluid that's around the tissue expander inside the body. What you do is when you insufflate it, you can watch this on YouTube. If you go to YouTube, Thomas McClellan, you can see how all this works.
YouTube what? Video guy?
Thomas McClellan,
Okay.
YouTube, or Morgantown Plastic Surgery.
His name. Yeah.
Yeah.
I'm just telling the video guy over there.
Use a little magnet. And you run the magnet over this metal port, and it goes through the skin, and it helps you identify where the port's at. So you can take saline in a syringe, stick it in this metal port, and safely put fluid inside the tissue expander.
Did you invent that?
The tissue expander, no. This particular tissue expander,
You did?
yes.
Awesome.
So what I did is if you have this fluid around, I had them build in a second port, okay? So if you have this port here, what you can do is, if you have a seroma, you can stick the needle in this second port safely, okay?
And draw.
And you can draw off the fluid. Look at that. See how the fluid comes off?
I
He
do.
is actually drawing fluid.
So if you do that, the patient
Does not have to go through another
should
surgery.
not need surgery. That's number one. So you could draw off a seroma. This is why I like it. Let's say that their breast is red after surgery. Well, redness could be caused by a lot of different things, not just infection. But how do you know? So what I'm able to do, let's say that this is some infectious process. I could draw some off, okay? Put it in a petri dish and send it for culture,
Sure.
okay, so that we can treat it. This is the best thing, though. Let's say that I take a bactericidal antibiotic, a antibiotic that kills bacteria on contact, okay? I can take that antibiotic, I can go into the port safely, and remember I told you around there, there's no blood supply, so you can't treat it. Now I can effectively inject antibiotic into the pocket and kill everything in the pocket. And so the woman may not have to go back to surgery. We may have saved a woman a surgery.
Unbelievable.
We're going to take a break
Wow,
right now, Dr.
congratulations.
McClellan. Hang on just a moment. Dr. Tom McClellan, our guest this morning, and we're talking about breast reconstruction surgery this morning. 304-296-0041 is our number.
This is Mon General's Health Talk. If you have a health-related question, call us now at 304-296-0041.
Dr. Tom McClellan, yes, he's a doctor. He's also a teacher and an inventor. Man, you are very accomplished. A teacher of the year, 3 years.
You know, we can sit here and brag about it, but as we were talking in the break, the knowledge and what we have right here in Morgantown, West Virginia, just from what we're getting from you this morning is just amazing to me.
You do use, you can use silicone and saline, right?
At the final surgery, or the second stage, when you take out the tissue expander and you put in the implant, you can use saline or silicone.
What would be the deciding factor? I just want to ask that.
That's what I was going to say. What's the difference?
You're asking good questions this morning, Kay. It's what patients want. If you want saline, I don't choose for the patient. I let them choose. Both implants have pros and cons. One of the pros of saline, if it ruptures, you'll know immediately. It will go flat. Whereas a silicone implant, you would not know. You would need an ultrasound or an MRI. One of the negatives to saline is it tends to show rippling through the skin, through thin skin. Over time, as the pocket around the implant gets smaller and squeezes on the implant, it tends to show little ripples around it. That doesn't happen as often with silicone implants. And then finally is just the feel of it. The woman wants a nice, soft, natural feeling breast, and silicone tends to be more like that.
Okay, so if you'd sit down, you'd have to discuss all that and let them make the final decision.
And if they're concerned about silicone implants, even though they are safe, then we go with saline.
I know you're talking about reconstruction. What about a deformed breast or deformity of some type? Can you do the same thing of what we're talking about today for reconstruction?
Sure. there are all sorts of asymmetries that women have. One of the most common is seen in younger girls. It's called tuberous breast deformity, which is actually quite common. Tuberous breast deformity is basically you get a concentric ring of not scar tissue, but congenital scar tissue, a band of tissue that prevents breast development so that you do not get a lower pole fullness of breast development. This constricting ring herniates the breast tissue out through it, and so you have very small kind of pointy breasts that obviously women don't like. And that's considered a breast reconstruction, not a augmentation or a cosmetic procedure. You can address it in two ways. You could just put an implant in, or some people stage it to a two-stage procedure where you do a tissue expander like what I showed you, and then an implant. It depends on the severity.
What if a woman doesn't want an artificial implant?
You can do a muscle flap, which is an autologous, or you kind of own the tissue. But I always tell people that you have to give something up to get the muscle flap. And generally that's a scar on your body somewhere else, bless you, such as from your back or from your belly. And it's a longer surgical procedure. Generally, you have to stay in the hospital longer. However, the benefit is typically you do not have secondary procedures.
Is it the most natural looking?
It is. Some people that want a tram flap, they want their belly a little bit tighter. They all come, every breast reconstruction has some positives and negatives. For example, if you have a tram flap, which is from the belly, you can get a hernia. Or you can lose your belly button, things like that.
304-296-0041. Dr. Tom McClellan, our guest today. We'll take our final break and be back to Health Talk, brought to you by Mon General on WAJR right after this.
This is Mon General's Health Talk, providing the information you need to take charge of your health. Call us now with your health-related questions at 304-296-0041.
Dr. Tom McClellan, our guest on Health Talk on WAJR. And he's also with Morgantown Plastic Surgery, and we were talking about breast reconstruction surgery. And we talked about several different procedures, but putting it in a nutshell, I'm going to trust you to determine what procedure is right if I'm a woman, which I'm not. But how do we know, if we want to try to make up our own mind, which surgery type is best for us?
Great question. A couple comments. One, make sure you talk to your general surgeon. We have wonderful general surgeons at Mon General that participate as a team. They don't make unilateral decisions, and they give you all the options. That is very special and not everywhere. Talk to them, come to me. Every patient is different, and frankly, some patients are not candidates. Smokers, diabetics, etc., are usually delayed candidates, not immediate candidates. And so we work through their health history with them and try to select the best option for them.
I would think most of the time breast reconstruction is you're referred to by the surgeon, or you're referred to. I mean, it's not, I'm going to elect to get reconstructive surgery, right?
Well, some ladies are not ready at the time. They want to deal with one thing at a time and compartmentalize it, and that's okay. You can do that, but with the skin sparing mastectomy, if I talk to the general surgeon in advance, we can get the incision I want because we've designed an incision with the local general surgeons that's better, it looks better. So we can get them to do the incision, save all the skin for us, and we'll come back and fight another day and still get a great result.
Very soon you'll want to look for the video on the Mon General website of this show. Very informative with Dr. McClellan this morning, and we do videotape each and every one of these programs, Health Talk by Mon General. mongeneral.com is the website address. You can see some of the past shows, but you'll want to look forward to seeing this one as well because he brought visual aids with him today. Thank you so much.
Radio. Thanks, guys.
Appreciate it. Morgantown AM coming up after the news on 1440 WAJR.